Greetings, I'm Dr. Kim Kyung-won of Online Surgery. I'm honored to share a surgical clip with you today. Let's look at today's patient at initial visit. The patient is a 73-year-old male patient. At initial visit, as shown, in the upper, there were not a lot of residual teeth. There was a lot of mobility in number 25, and the bridge in the lower anterior, it was mobile. In the case of this patient, as for the maxilla on the right side, sinus surgery was necessary. The patient had a little bit of hypertension and cardiovascular disease, and the patient was taking aspirin. The patient said he was smoking for over 50 years, and before he came to my hospital, at another hospital, he heard that sinus graft was necessary and that smoking can be a problem in this case. Treatment plan: extraction of number 25 in the upper. From 11 to 23 in the upper anterior, bridge is going to be provided. Temporary denture is going to be provided. Surgery is going to be proceeded. The patient thought long and hard and decided he was going to quit smoking, and he wanted to proceed surgery after he quit smoking. The reason why the implant surgery was delayed was because the patient was older and he had gastrointestinal disease, and he was hospitalized because of that, and that caused a delay in surgery. This is July 2021. The lower anterior were extracted first. In upper anterior, fixed bridge was provided. In number 25, this is extracted. In CT, in upper right, posterior area, there's not a lot of alveolar bone left, and it's quite clean within the sinus. Number 12. The alveolar bone amount itself is quite favorable. It's quite narrow, but it's okay. In number 14, the alveolar bone is favorable and there will be no major issues in placing implants. In number 15, as you can see, there's not a lot of alveolar bone and sinus graft is necessary. In number 16, it's in need of attention as well. Last kit core drill is going to be used to form lateral window on the sinus. Bone graft is going to be done and implant is going to be placed. As shown, in the lower posterior area, immediate implants were placed. In the case of upper left posterior area, implants were placed. And number 25, the bone quality was not good, so sucker preservation was done. Today we're going to do surgery on the upper right. The surgical plan is to place implant in number 12, and in number 14, I'm going to place another implant. These two areas are not directly related to sinus area. Last kit is going to be used for sinus lift. The bone graft is going to be done, and 2 implants are going to be placed. A total of 4 implants are going to be placed. This is immediate post-op as planned. In number 12, 14, implants were placed, sinus bone graft was done, and 2 implants were placed in this way. Post-op CT image, number 12 and 14. For number 12, at the time of implant placement, the thread was not exposed, but because the alveolar bone was slightly thin, a GPR was done. Xenograft was done. Bone graft. Number 14, implant was placed without major issue. In the case of number 15, we formed a lateral window using last kit. You'll be able to see it in the surgical clip, but the sinus membrane perforation was quite severe. The patient had been smoking for over 50 years, and I think that had something to do with it. Comparatively huge perforation occurred, but you can see that graft material has not dispersed within the sinus and is concentrated in the sinus floor. I used fibrin glue to do repair. In number 16, graft material has been grafted nicely in the sinus floor. It is not dispersed within sinus cavity, and fibrin glue was used to do repair completely. Unlike collagen membrane, in the case of fibrin glue, it goes in liquid state, and once fixated, you can fixate graft material in the lower part of the sinus as the fibrin glue solidifies. In this case, you'd be able to observe it heal without major complication. Let's look at the surgical clip. Fortunately, the patient was able to quit smoking, although he has been smoking for over 50 years. We were able to do surgery in a safe manner. Complete temporary denture was placed to check the relation with the antagonist. You can see that the fixed bridge prosthesis was delivered in the anterior area. Temporary denture is removed. I'm checking the surgical site. Incision is being made. Crystal incision is made slightly palatally, so vertical incision was not done extensively. Flap elevation is done. I'm going to place implant in number 12. In that area, I'm using lens drill to check the implant placement position. I'm avoiding the root of adjacent teeth. 2.22 twisted drill is used. Parallel pin is used. Guide pin is placed to check the relation with antagonist. After that, 3.5 wanted to taper drill is used for drilling. 4.0 by 10 wanted to taper drill is used. I didn't do full length. KS3 BA 4.0 by 10 millimeter implant is going to be sufficiently irrigated, and now I'm going to position it. Implant thread was not exposed, but buccal bone feels slightly thin. And you can see that with your eyes. Torque wrench is used. With my hands, I'm checking the position and placing it sufficiently deeply. I'm going to skip number 3 and I'm going to place in number 4. Length drill is used. After that, 2.2 twisted drill is used for drilling. Sinus floor is not penetrated. Parallel is placed to check relation with antagonist. It feels slightly buccally inclined. Therefore, path will be altered slightly. Depth gauge is used to check whether the sinus floor is penetrated. Side cutting drill is used to alter the path more palatally. Twisted drill is used once again to get position. Parallel pin is placed to check relation with the antagonist. You can see it is more palatally inclined compared with before. Depth gauge is used to check whether it's been perforated. I'm going to use a 3.5 by 10 millimeter wanted to taper drill, and 4.5 by 10 millimeter wanted to taper drill is used. Final drill is only going to be up to 4.0, and as for the implant body, KS3 BA 4.5 by 10 millimeter is going to be used. This is a hydrophilic surface, so you need to irrigate it sufficiently and then position it. In order to form sinus lateral window, flap has been reflected. 7.0 core drill is used to form lateral window. 1 millimeter stopper was used first. The lateral wall of the sinus is thin. If you do 1 millimeter core drilling, you can see that bone lid has been removed nicely. Fourier elevator is used to lift the sinus membrane. As mentioned earlier, the patient has been smoking for over 50 years or so. The membrane was quite thin. And when I was lifting the mesial side of the membrane, a big perforation has been formed. In this case, perforation occurred significantly on the inner surface, so it's difficult to do repair. And I didn't want to stop the surgery, so in this case, I just lift the membrane sufficiently on the lateral side of the nasal cavity and proceed with surgery. I'm going to show you how repair is going to be done. In number 5, lance drill is used. I'm checking the position. 2.2 twister drill is done. You can see sinus floor is penetrated. Parallel pin is used to check the relationship with the antagonist. In number 16, I'm checking the position with lance drill. 2.2 twister drill is used. Sinus floor has been fully penetrated. Parallel pin is used to check relation with the antagonist. .5 by 8.5 1-2 taper drill is used. Drilling is done. 4.0 by 8.5 1-2 taper drill is used. 3.5 diameter implant is going to be done. Final drilling is going to be done up to 4.0. As I prepare bone graft material, I'm using the gauze which is irrigated. There's not much bleeding, but I'm controlling the site as we prepare fibrin glue and the bone graft. The fibrin glue is actually frozen, and you can see how I unfreeze it. If the sinus membrane is torn, you can use fibrin glue to do sufficient repair, but it can still affect the formation of bone using bone graft. In this case, I prepare allograft in the tray ahead. You can see that I've done that on the tray. In this case, sinus membrane was perforated significantly. The graft material can disperse into unwanted area. I use SureOs, xenograft, as well as AOS, and I irrigate it sufficiently and proceed with bone graft. I place SureOs on the host bone first. The patient is lying down. It can go into unwanted area, so that in order to prevent the graft material dispersing too much, as shown, I'm putting the bone graft material in the front and lower side. I put sufficient amount of bone graft and then layer it with AOS xenograft material. You can see the perforation. We need to take care so that it does not disperse too much. After that, KS3 5.0 by 8.5 millimeter implant is placed after sufficient irrigation. If there's membrane perforation, the graft material, it should be prepared ahead so it's not exposed for extended period of time. We need to reduce the amount of time it is exposed within oral cavity to prevent infection. KS3 BA surface, a 5.0 by 8.5 millimeter implant is placed. The residual alveolar bone is only 1 to 2 millimeter. You can see that primary stability is okay. Because the residual alveolar height is not high, there's limitation in placing the implant deep. Implant driver is used to get the final implant position, especially in the mesial side. Alveolar bone height is sufficient, so I place it deep. On this side, I adjust the depths as well. Within the sinus, in order to do repair, fibrin glue is used. There is significant perforation in the inner surface. Fibrin glue is used so that the bone graft material does not go into the sinus cavity. This is used also to repair the sinus membrane. When you use fibrin glue, in the case of severe perforation, it is difficult to apply collagen membrane. At times, it does not cover sufficiently. Therefore, if you use fibrin glue, you'll be able to repair it more easily. In number 12, there was buccal concavity in this area. I'm going to use the bone lid here instead of using it in this sinus lateral window. This is autogenous bone, so I'm going to use it. And on top of it, I'm using EOS, the bone graft, xenograft. Oscide collagen membrane is going to be used to do GBR. Resorbable membrane is used. In this case, you just do adaptation. Periosteal releasing incision was done, and you can see that flap is closed, tension free. I do periosteal releasing incision sufficiently to do tension free closure. I am doing suture in this area in order to adapt it well. In the case the flap is torn, you can use adjacent teeth and do anchor suture. Check the margin. I think we'll be able to get nice closure here. As for the remaining area, I'm going to do figure of 8 or interrupted suture here to get closure. I've shown you my surgical clip. As shown in the clip, in this case, when I used the last kit to do lateral approach, at the time of window formation, there was no perforation. However, when I lifted the membrane towards the inner surface, because the patient smoked for a long period, sinus membrane perforation occurred. It was quite a significant perforation on the inner surface of the sinus, and I lifted the residual membrane, did bone graft. After that, I used fibrin glue for repair. I'm sure all of you are interested as to what the post-op will look like when significant perforation is repaired with fibrin glue. This is post-op 4 months CT image. I'm going to share with you the follow-up image. This is 4 months after surgery. As you can see on the panoramic image on the left, it's immediate post-op image, and this is 4 months and 10 days after surgery. You can see that on panoramic image, the bone graft is well maintained. not just on X-ray. Clinically, the patient does not show any signs of post-op infection. As you can see, this is immediate post-op. Number 12, you can see GBR was done. 4 months later, the bone graft material is well maintained here. There are no major problems and it's being healed. In the case of number 14, there's no big difference between immediate post-op and the 4 months after image. The number 15 is where the sinus membrane was perforated during lateral approach. Bone graft was done. Fibrin glue was used to repair. Within the sinus cavity, the graft material did not disperse and repair was done nicely. After 4 months and 10 days, you can see a lot of fibrin glue resorption on the top. The bone graft material itself is being consolidated and it's healing. Yes, we cannot really see for ourselves how the sinus membrane has healed. But when you compare with immediate post-op image, you can see that there's some sort of a membrane with less radiopacity. But after 4 months, you can see it barely on top of the bone graft material. It is being healed nicely. This was number 15. In number 16, graft material can be observed. Fibrin glue was quite thick above after 4 months. The graft material is well maintained. On top, there's nice healing as well. On CT, you cannot really see the state of sinus membrane in post-op image, but you can see that the graft material is being well maintained in the sinus even after 4 months. In other words, it's healing without a major problem. What I wanted to say with this surgical clip is that you can use fibrin glue. I really use this often in the case of sinus membrane perforation. Regardless of the size of perforation, you don't need to delay the surgery. You can just lift the remaining sinus membrane and do bone graft. After that, you can proceed. In the case of bone graft, on the host bone site, I use allogenic bone, and on top, I use a xenograft, in other words, bovine bone. I use EOS to do bone graft, and in the area where perforation is, I use fibrin glue for repair. I've shared with you the image after 4 months so that I can demonstrate how fibrin glue can be used successfully for sinus membrane perforation repair. Thank you for watching.